right, everyone, we're going to go ahead and get started. And as people come in, they can just fill in where catch up. So, my name is Patricia. I'm with Thrive Kids, and we have our presenter today, Sonia Washington. This is a virtual training for Louisiana school nurses, and we are very excited to be here today, partnered with Louisiana Department of Health and Louisiana Department of Education. Sonia, if you want to go ahead to the next slide. So I'll do a brief introduction, and then Sonia will go ahead with her presentation. And then in conclusion, I'll come back and let you guys know how to ask questions. So like I said, I'm Patricia. I'm with Thrive Kids, a student wellness project. We're very excited to be here today with this professional development opportunity. We are excited to be changing the health of generations beginning in schools. This is a very great program that we've developed that we are ecstatic to get going. As I said, we're partnered with Louisiana Department of Health, Well Ahead, and Louisiana Department of Education. Our presenter today will be Sonia Washington. She is our expert in diabetes management. She has a lot of communication with a lot of school nurses in the area, so you guys may be familiar with her. She's very knowledgeable. We're very happy to have her here today. And at the bottom, you will see the Thrive Kids email address. If you have any questions, please feel free to put them in the chat box. And if we can get to them at the end, we definitely will. Otherwise, if we can't, include your email address. That way we can email you with any responses necessary. Sonia, you want to go ahead and get started?
Okay, thank you, Patricia. I appreciate that. My name is Sonia Washington. I have been a nurse for 28 years. I have been with pediatrics the entire time. I started back in 1999 working here as a diabetes nurse, left and went into the school system and taught nurses for 15 years and came back to children's back in diabetes. I always taught diabetes when I was teaching nursing. And hopefully, I can give you some information that is maybe a refresher, maybe new to some, but all in all, I think you'll enjoy it. So today, we're going to start off with the difference between type 1 and type 2 diabetes. Type 1 diabetes patients require insulin for the rest of their lives. What happens is the pancreas, for some unknown reason, because there's still no real etiology of why people have type 1 diabetes. They have had some studies to that reviewed familiar reasons, genetics as maybe a reason for it, but it seems to just happen in some families where nobody in the family has diabetes, and then all of a sudden their kid pops up with type 1 diabetes. So what happens is the pancreas stops producing beta cells because of the autoantibodies, and they the reason for beta cells is to produce insulin. And so what happens is the insulin is not able to get into the cell. What insulin's job is to open the cell and allow sugar to go into the cell and to be utilized for energy. So when there's no insulin, then they're not able to get any sugar into that cell. So then the cell begins to burn fat for insulin, and then that's where our ketones come in. Now, type 2 diabetes, they may require insulin if their A1C is over 9, they will be put on insulin. If not, they will just require pills. Most of our type 2 patients are on metformin if they could tolerate it, because metformin lots of times give you GI problems. And so some patients can't tolerate it. And so we'll move to some of the other, maybe Victoza or something like that. I put diabetes ketoacidosis under type 2 because with type 1s, they could actually go into diabetes ketoacidosis within about 3 hours. Type 2 is very subtle, but they actually can go into diabetes ketoacidosis if they go for a long time without taking insulin, or their blood sugar just continue to rise and rise and rise. And so sometimes, like recently during COVID, we've had a multitude of type 2 diabetics. Now, type 2 diabetes is more familiar. Like you have to have, it's usually a history of family members with type 2 diabetes. They have somebody in the family with type 2 diabetes, and that has been studied, that type 2 are genetics. And so they will usually look a certain way, and we'll get into that on the next slide. Whereas type 1 diabetes, they will have a lean body size, as I stated earlier, some to no family history of type diabetes, type 1 or type 2 diabetes. With type 2, they can be lean, but usually obese. They usually have a family history of type 2 diabetes. And they usually have, if you've ever seen kids with a dark ring around their neck, that's called acanthosis nigricans. And that happens in kids with type 2 diabetes because they are actually insulin resistant. That means that their pancreas is working, it's pushing out the beta cells are producing insulin, but the insulin is taking a break. So it's not opening up all of those cells, allowing the blood sugar to move into the cell for energy. So we call that insulin resistance. And as I stated, it can be helped with pills, which will help the liver to push out more insulin. It can also use insulin to help with that as well. Now, signs and symptoms of diabetes, and I put this on here because I want to first congratulate all of you guys for your work on the front lines and for your service with our kids, because you are an integral part of their lives. When they're in school, we know that they're at least getting their lunch insulin. Not all kids get take their insulin all the time, as you know. But we know that when they go to school, they're taking their insulin. So kudos to you and thank you for being there. Increased thirst, increased urination, and increased hunger are the cardinal signs of new onset diabetes. The reason I'm bringing this up to you is because a lot of times diabetic ketoacidosis, or DKA, can be prevented if it is found early on that they have their A1C is elevated, and then we will do other tests to test their autoantibodies to determine whether they're type 1 or type 2. But if you notice that a child is, or a teacher tells you that this child is leaving the classroom a lot because they're going to the bathroom, or they're always drinking something or eating something, then that should raise a red flag. And you should bring this to mom's attention and tell her to go to her PCP and have them to do an A1C, which is a simple test that can tell us if they are on the verge of developing diabetes or if they have already developed diabetes. Uh, Anything over 6.5, 6.6, we consider diabetic. So other things that can happen is that kids who are, especially with type 2s, they may be in the classroom falling asleep in the classroom. And that may be the only thing that you notice, is that every time you turn around, they're nodding or they're dozing in the classroom. That may not be from staying up all night playing video games. That may be because their blood sugar is really high and it's making them very tired. So that's another thing that you want to look into when you have a patient and help to prevent the diabetes from happening. So let's talk about what you deal with every day. Insulin doses. So a long time ago, before they had what was called the diabetes trial, DCT trial, everybody was basically on 2 shots a day. And 2 shots a day, it works, but you have to be very regimented with 2 shots a day. Like, you have to eat breakfast at pretty much the same time. You have to eat lunch at the same time. You have to eat dinner. You have to have snacks. So a lot of nurses will ask us, well, why do they have to have a snack? Or why does one have to have a snack and the other one does not have to have a snack? Well, here's the reason why. If you look at this slide, this picture right here, this picture shows you 2 shots a day. And you can see that you take the first shot. This is regular insulin. So this is when you used to have to wait 30 minutes before they eat anything. And it would peak somewhere around here at the two hour mark. But here you see they have the short acting insulin. So the short acting insulin works in about 5 to 15 minutes and it peaks in about 90 minutes. And it's gone in 3 to 4 hours. But what I want you to look at is, you see right here, this is where the NPH is starting to come in. And so this is why they need a morning snack, because they still have the short acting insulin on board. And now you're adding the intermediate acting insulin. So they need a snack here. And then this is dinner time. 12 hours later, it starts to go away. And so you will need a snack in the afternoon because it's still kind of giving a lot of insulin. And then it's gone by dinner. So then you start you start it all over again. So you're giving the short acting, and then you're going to give the long acting. They'll have a bedtime snack, and then that I'm saying long acting, but this is intermediate acting. It'll last until they wake up in the morning. So they require snacks. 2 shots a day, they require snack. Now, we don't have a lot of patients on 2 shots a day. And so most of our patients are on what we call multiple dose injections or basal bolus. And basal bolus is what you see down here. They receive either Lantus, Tresiba, Levemir, and it just gives a little bit of insulin all day long. This mimics more, and this is what that DCCT research study found, that the more intensive insulin regimen, it actually mimics what our body does. So if you don't have diabetes and you eat a peppermint or you eat a cracker or a piece of bread, your body is going to throw out some extra insulin and take care of that for you. And you don't have to worry about doing anything. But for diabetics, we have to figure out a way to do that for them. So this Tresiba or Lantus or Levemir, it lasts for 24 hours. Actually, Tresiba lasts 72 hours, but we still give it once a day. So they will either take it in the morning or in the evening. And if you see these little mountains right here, this is the short-acting insulin. So they would get, this is called basal. Basal insulin is the insulin that they're getting all day long. This insulin they should never miss. So if you're talking to them and you teaching them, then let them know that if you're going to miss an insulin, you don't want to miss the long-acting insulin, because then once you take that short-acting insulin, you don't have that much left. In 3 to 4 hours, it's gone. So it starts in 5 to 15 minutes, it peaks at 90 minutes, and in 3 to 4 hours, it's gone until the next time you give an injection. And so we give injections for food. And the injections are based on carb ratios. So you may have a carb ratio of 1 to 10. So then you would figure out how many carbs this child is going to eat and then divide by 10. And in addition to that, if their blood sugar is above a certain number, if it's above 150 or above 200, then you have to give an extra unit of insulin for the correction. Multiple dose injections work, but it's hard work. And so you have to make sure that they're getting their insulin for breakfast, lunch, and dinner. And why I say that you guys are, kudos to you, is because we have had some nurses who actually, because most of the time they get their morning insulin at home and they eat, but sometimes the kids, they want to be like everybody else. And so they want to go to school and eat the breakfast at school. So we have a lot of nurses that will give the morning insulin. Some of them will even give the Lantus to make sure that the kid is getting the insulin. So we really appreciate that effort on your part. And the pump is the other option of insulin regimen, and we'll get more into the pumps, but the pump only takes the fast-acting insulin, the Humalog or Novolog. There's also a Apidra, which is a fast-acting insulin that we usually don't see anymore with our patients. Most of them are on either Humalog, Novolog, the generic Lispro, or Aspart. So they're usually on those insulins. And the pump, they would take just the short-acting insulin. So that's why we're going to talk more about the pump as we move forward through the slides, because that's a whole different ball game. So where to give injections? On the back of the arms, on the little fatty part of the butt, right at the top of the butt, you can give insulin on the belly, as long as it's 2 finger breadths away from the belly button, and of course on the thighs. Now, you see how they have all of these little boxes? That's because we want them to rotate in different spots every time they give insulin. Because when they don't, you may have recognized this in some of the kids, they will have a puffy area on the belly, or a puffy area on the arms, or on the legs. And that's called lipohypertrophy. And that comes from using the same spot over and over again. Now, why do they use the same spot over and over again? Because as the scar tissue builds up, they don't feel it anymore. So, but at the same time, it's not being distributed the way it's supposed to be. And so that can result in high blood sugars. So we talked about pumps, and here are our 3 main pumps. This is the Omnipod pump. That's the little pod that goes mainly, you'll see it on their arm. It sticks to the arm, and it is the whole mechanism is the brain of the pump, this little pod. This guides it. The pod talks to this, but this is a PDM, and it's really a tool to tell the pump what to do. So that's where you will put in the carbs and the blood sugars. The Medtronic pump, you may have some kids that have the Medtronic pump and the Guardian sensor. So the Guardian sensor speaks to the Medtronic pump, and it goes into what is called auto mode. So with auto mode, the only thing that you have to do is put in the carbs. Now, it will ask you sometimes to calibrate the sensor. So, and what that pretty much means is that you are checking your blood sugar, your finger prick, and putting it in the pump so that the sensor can recalibrate. And soon they'll be coming out with, and we'll talk a little bit more about CGMs as well. But with the pump, it changes every 2 to 3 days. Most people change it every 2 days. And so you're not getting 4 shots a day. You're getting 1 injection for the pump on every 2 days, every other day. The t:slim, this pump is now combined with the Dexcom. The Dexcom CGM talks to the t:slim, and it has a feature called Control IQ. So auto mode and Control IQ works somewhat similarly in the fact that if the blood sugar is high, the pump will automatically give more insulin. If the blood sugar is low, the pump will give less insulin, or it will suspend itself. Now, those are very good features of both of these pumps. One of the disadvantages that a lot of parents find with this pump and this pump is that it has the tubing. So with the tubing, you have to kind of be creative of where you put it so it doesn't pull. And then the other part is that the tubing can get kinked, and your blood sugar can go up. And remember, this is only short-acting insulin. So if the pump stops working, you only have 3 to 4 hours after your last bolus before you have no insulin on board whatsoever. So for a type 1, they will go into DKA pretty fast. So it's important that if you give a bolus and you're still high in an hour, then you want to check for ketones, check the pump. The first thing we do is tell them to change the injections, change the infusion set. That's what this is called, an infusion set. Change that site and put in a new site and a new reservoir, which goes into the pump. Now the parents do that. Some of the kids know how to do it themselves. And we've had some nurses who wear pumps who are very helpful to the kids with the pumps. And so the 3 types of pumps we have are the Omnipod, Medtronic, and t:slim. That's what you will cover. The advantages of the pumps are that it tries to maintain them within a range, and our range is either 80 to 150 or 80 to 180, depending on the age of the child. And so it helps to kind of pull those highs and lows together so that we'll have a steady spray of blood sugars. So the CGM, which is an acronym for continuous glucose monitor, you have the Guardian that is with the Medtronic. You have the Freestyle Libre 2, and that's a standalone. And then you have the Dexcom. The Dexcom is the one that works with the t:slim. Now, some patients will be on multiple dose injections or bolus basal regimens and have the CGMs. The good thing about the Dexcom G6 is that you don't have to calibrate at all, and you can dose off of it. The FDA has approved that you can dose off of the Dexcom G6. So it's great because they don't have to get their finger pricked, and then you can see what the blood sugars are, and the parents can see what the blood sugars are. So they're on the phone. The only thing is that a lot of these kids will have to have a phone in school because their blood sugars are on their phone. So we have the Dash, which is strictly on the phone, and then you have the Dexcom G6 with the reader. So the Dexcom is what we have most of our kids on. The Freestyle Libre 2 just recently came out for pediatrics because it was a 14-day sensor for adults, the Freestyle Libre. Now it's still a 14-day sensor, but it's approved for pediatric patients over 2 years old. And then the Dexcom is a 10-day sensor, and the Guardian, I'm pretty sure it's 7 days. So these sensors are very good. They give you good information. One of the downfalls is that, and we've had some issues with this, is that with the Dexcom, it'll show you an arrow going down. So you may have, they may be at 100 and they're showing 2 arrows down. In 30 minutes, it can go down to 90 points. But you can't start treating them at 100 because they're not low yet. So you wait until they get to 70. It may level off, or it may you may have to treat them. So you want to look at that. If it has an arrow going straight out, that tells you that it's steady at that. If the arrow is going up, that means that the blood sugar is climbing, and you'll probably see that after they eat. And then if they're having, if it's going down, when you may see that when the blood sugar, when the insulin is peaking at 90 minutes, you may see it going down. And sometimes you'll see 2 arrows, and that means that it's going down pretty fast. So you just have to watch it. And when they get to 70, then you want to start treating them for a low blood sugar. But you always have to prick their finger. If they're running extra high or if they're running low on the Dexcom, you have to prick their finger. That's the only time that they have to get a finger prick. You have to prick their finger to see if they're actually low, because the CGMs, the continuous glucose monitors, they are, it is a catheter that is in the interstitial fluids. And so there's a lag between the interstitial fluids and blood. And so you're going to have maybe a 30, sometimes 40 points difference between what the finger prick is and what the Dexcom is. So that's why when we see a low, and if it's extremely high, we want to prick the finger to make sure that that's what it is before we start doing a treatment. So while you can treat off of the Dexcom, if it's a low, you have to do a finger prick before you do any treatment. And then and make sure that they are low. Hypoglycemia. Too little food, too much insulin, too much exercise without food. So what we say is, for exercise, they should be testing their blood sugars before they exercise, during the exercise, and after the exercise. And they should have 30 grams of carbs for every hour of exercise. So when you have kids that are on the football team or the basketball team or the soccer team, or even cheerleading, this is how you want to treat them. You want to make sure that they have enough carbohydrates to uphold their exercise, because if not, then they will have a low. Here's a little guy, he's having a low. Lows, you get shaky. Shaky is very common. Shaky, sweaty, hungry, headachy, dizzy, confused, grumpy. But they can get very low, less than 70. They can drop in the 40s. And so they could have unexpected behavioral changes, visual changes, drowsiness, weakness, or difficulty talking. They can even lose consciousness or have a seizure. But we can help them with this. So, but while we're talking about low blood sugars, I want to talk to our nurses who talk to who may have kids in pre-K or and some of those kids, they can't tell you that they're having a low. They don't recognize the low. And so you have to pay attention to them and ask mom, because they usually can tell you that if they start clinging to you, if they start whining for no reason, if they just go sit in a corner, those are all reasons why they may be having a low. So with kids, it's with the little toddlers, it's a little tricky. So you want to be aware of that if they have hypoglycemia unawareness. So what do we do for lows? If mild to moderate, so if they're running 60s, 50s, I mean, even 40s, if they still up and awake and able to drink or eat, we're going to give them 15 grams of a sugary snack. And I have here Coke, orange juice, glucose tablets, but they could have apple juice, a half a can of Coke. They don't need a whole can because that can just send them up high. Like 4 glucose tablets, 4 peppermints. They have these little gushers that people use. They have the little packs of gummies that people use that will also work. The key is to check the blood sugar in 15 minutes to see if you're starting to get a rise in the blood sugar. If the blood sugar is still not above 70, then you want to give 15 more grams. But this time you want to add some protein, or if it's time for lunch, let them eat lunch. And don't give them the insulin. Let them eat lunch to get up. If it's severe, there's 2 things that happen. If they are not eating and you can't get them to eat anything or you can't get them to drink anything, you should be asking mom to send you a tube of icing as part of their little package when they bring you their insulin and glucagon and all those things, because it may be that they're not unconscious, but you just can't get them to drink or eat. So you could just squeeze that tube of icing into their cheek, and that will work as well. However, if they become unconscious, then you're going to give them glucagon. And when you give them glucagon, it works fast, but more times than not, it'll make them vomit. So you want to turn them on their side and then call 911. Now, we'll look at glucagon because now we have choices. Before, the only thing that you would get was this one in the middle, this red container, where you had to mix the liquid with the powder, shake it until it was clear, and it was a very long needle that had to go into the muscle. Well, now we have options. We have Baqsimi. Baqsimi works like, you've probably heard of Narcan. It kind of works like that. So it comes out, it has, you could see it in this person's hand. You stick it up the nose until your fingers get to the end, and this little piece that is pushed in. This is one that's completed, but it'll be pushed out, and all you do is push it in. And if you go to, I have on your objectives, if you go to the Baqsimi website, baqsimi.com, they have like a 60-second video for you to see, to show you exactly how to use the Baqsimi. Then you have Gvoke, it's sub-Q. Baqsimi, they have to be at least 4 years old. With Gvoke, they have to be at least 2. So with the little ones, if they're less than that, then we're back to the red box again. But so that makes it easier to give the glucagon, because you don't know how many times we've had parents who've had to give it at home. They forget to mix it. They give just the liquid. So it doesn't work. With the Baqsimi, you could repeat it in 15 minutes if 911 hasn't come by then. So that is the hypoglycemia. The hyperglycemia, it looks like we'll have time for questions because I'm going a little faster than I thought I would be. But with hyperglycemia, you're going to give too little insulin, not giving insulin, infections or illness, traumatic body stress, if they break a limb or, you know, have some type of traumatic accident or a pump malfunction. Any of those things can lead to high blood sugars. Any of those things can lead to DKA, diabetic ketoacidosis, in type 1s in about 3 to 4 hours. If they have not had their insulin, if the pump has malfunctioned and they're not aware of it, then they can go into DKA. Now, what is DKA? DKA, and I'll get to that on the next slide. It is a cascade of things that happen because the body does not have energy, have that glucose for energy. And it's because those cells are not being opened with the insulin to allow the glucose in. So they have to give their insulin. They can't get away around it. They have to take their insulin. With type 2s, as I stated earlier, it can happen. It just takes a little longer to happen because their body is still producing some insulin. So they still have a little protection mechanism. But I could tell you that we've had some type 2s with 300 and 400 blood sugars. And so that's another thing. When they're at school, if they have 300 blood sugar and ketones, they cannot go to football practice. They cannot go to basketball. They cannot go to soccer. They cannot do any exercise because that will increase the acidotic portion of the body. So if they have high blood sugars and ketones, you don't want them to exercise. Now, if their blood sugar is just high, hydrating and exercise may actually work to help lower it. But with high blood sugars, they'll have increased thirst, increased urination. Ketones, they tell me I'm the ketone queen around here because I could smell ketones. If I walk in an exam room, I will tell you, you have ketones because I could smell them. Once you smell them, you'll never forget them. But they really smell like fingernail polish remover, like acetone. So, but they'll have a fruity breath. They may have stomach ache, nausea, and vomiting. They may also have labored breathing, like they can't breathe, they can't catch their breath. They may have chest pain, extreme weakness, confusion, and eventually unconsciousness, which is very dangerous because with hypoglycemia, it happens really fast. But with hyperglycemia, it happens slowly. But they could end up with cerebral edema, trying to bring them back because it's a fine line. You have to make sure that you monitor whether they are, you don't want to bring their blood sugars down too fast. Trace, small to moderate, and large. Those are the three types of ketones that can occur during hyperglycemia and can lead to DKA. Trace, you're going to give them water. They need to drink like 12 ounces of water. I say a bottle water, the 16-ounce bottle water. They drink one every hour. Test their ketones every hour. And it's usually resolved. You could do that easily at school. Small to moderate, they still need the water. Always, always, always they need water, water, water. But with small to moderate, they also need injections. If they're on a pump, then we're going to give them an injection when they have ketones. If they're not on the pump, we will give them a correction dose. But we ask that for our practice, and I know it is very hard on you guys, and because you have orders from so many different people, but for us, we prefer that you call us if they have ketones, small to moderate or large, because we could tell you how much insulin to give, because a lot of times we may give more than their correction. We'll give like 10% of their body weight or something like that. But I want you to look at this little box up here where when you think of DKA, this is how we determine DKA. We look at the pH. You can't live with a low pH. So a pH between 7.2 and 7.35 with a bicarb of 10 to 14 is mild DKA. With a pH of 7.1 to 7.19, or bicarb 5 to 9, moderate. Severe is a pH less than 7.1 or bicarb less than 5. And I guarantee you, we have seen lots of patients with bicarb less than 5. And that's because they keep trying to treat it. Our motto is this: if you vomit once, you might be able to turn it around if you could get some fluids down. If you vomit twice, that's an automatic ER visit because you need fluids. You need to hydrate. You need fluids to flush the ketones out. The ketones, so remember we talked about the cells and how the sugar, the insulin opens the cell, allows the sugar to go into the cell and burns sugar for energy. Well, when you don't have that, the body still is going to try to burn energy. It needs energy. So it starts to burn fat for energy. So when it burns fat for energy, and the byproduct of the fat is the ketones. And that's what you're seeing when you see ketones. That means that there is no insulin opening up those cells. That sugar is just moving through the bloodstream, coming out in their urine, and trying to get out any kind of way it can. It starts to build up. They start to vomit, and then as their pH changes and their bicarb changes, then they start the nausea and the chest pain and the weakness, and it can get really bad. So it's something that you want to look. If they have large ketones, they need to go to the ER. If they have large ketones, then that's an ER visit as well. And with the pumps, I'm going to go back just a little bit with the pumps. If the pump malfunctions at school, either the parent has to come, if the child is not able to change, if the child is able to change out their site and get their pump back working, then that's fine. If not, the parent has to come to school, or you have to call and get an order, and they will be getting shots all day. Because if their pump is malfunctioning and the pump is not working, then they have to get a shot like every 3 hours throughout the day until they get that pump back on board. So that's very important, that they cannot just sit around with their pump not working. So if their blood sugar is greater than 250, and you check the blood sugar in an hour and it's still 250 or greater than 250, then something is happening with the pump. Because if you bolus through the pump, then it should bring the blood sugar down. Okay. So when you're running high and this is long-term complications of diabetes, most people think of these as adult illnesses, but it's really not. Like, we have kids who have kidney damage because their blood sugars have been over 10, over 11 for so long. And it can affect your eyes. We haven't really had any, I don't know if we've had any kids with blindness, but we've had their parents with blindness, kidneys, nerves. We do have kids with, excuse me, with nerves, where the nerves attack they what's called neuropathy, and it happens in their hands and their feet. They get these little prickly feeling in their hands and their feet, kind of like if you've heard the term my foot fell asleep, or my hand fell asleep. That's what they're feeling all the time. It can also affect your heart vessels. And so some of our kids are on enalapril. Enalapril is an ACE inhibitor that is used to protect the kidneys and keep their pressure at within normal range. So they have okay. So let's talk about the individualized health plan. I know y'all know this much better than I do, but the individualized health plan has to be done with the parent. And I know that you have some parents who have some special things that they want done. Type 1 diabetes and type 2 diabetes are self-management diseases. So sometimes the parents do choose to do things that we don't order for y'all to do. And so if they want to come to school and do it, then it's okay. But you're bound by the orders that are sent to you by us. We send out school orders every year after July 1st. And in between, as they come in, because they come in for visits on every 3 months. And so we do make changes when they come to clinic. Sometimes they'll send in blood sugar numbers. We'll make changes. And you play a role in that as well. So if you see their blood sugar, sometimes we get reports and we really don't need them because the blood sugars are fine. But if you see that the blood sugar is in the high 200s, 300s every day at lunch, and they're on basal bolus regimen, then we need to know that, because that means that the morning insulin needs to be changed. So the way the bolus basal works is, if they're waking up in the morning with high blood sugars, we go up on the Lantus. If they have high blood sugars or low blood sugars at lunch or at snack time, then we have to change the morning carb ratio. If they're having highs or lows at dinner, then we would change the lunch carb ratio. So that's how we make the changes for the insulin using the basal bolus model. Insulin storage. You want to store it in a cool, dry place. And once it's opened, it's only good for 28 days. The parents are taught this, they know that, but even if you give 1 or 2 units and that's all they end up getting for that 28-day period, then that insulin is no longer good. According to the manufacturer, it's only good for 28 days once it is open. The vials versus pens. The big difference with the vials versus the pens is that with the pens, you have to prime them with 2 units of insulin each time you use it. It comes with a pen needle, and so you have to take off the pen needle each time you use it, put on a new pen needle, and then do 2-unit air shot or 2-unit insulin prime before you give the actual dose amount. And with the glucose meter, as well as the Dexcom, when you're doing your teaching with students, it's very important to help them to understand that we're not just taking their blood sugars as a number. It's not just a number. It means something. So if I take your blood sugar at lunchtime and it's high, then at that point, let's talk about it. Let's talk about why you're high right now. Did you just eat something within the last 2 hours? Because if you you check the blood sugar, which we in the prior blood sugar check before eating is called preprandial, and then 2 hours after eating is called postprandial. So is this within that, between the preprandial and postprandial state? Is that why you're running high? Because you ate something or you drank something that was that had sugar in it? Did you remember to take your insulin in the morning? That's why you're high. Too much food, not enough insulin. So those are the kind of questions you want, and you want to try to get them into a mode of, when they're looking at the glucose meter, that it actually means something to them, so that they don't think, oh, I'm just checking my blood sugar, and it tells me how much insulin to take. No, it's a tool. It's a tool to help you to see where your blood sugars are. If your blood sugars are running low or running high, let's figure out why this is happening. There's a reason for this. Are you giving your injections in a puffy area? Do you have lipohypertrophy and you're giving your injections there? Because if you give your injections there, you may not know when the insulin is going to finally work its way through that. Ketone strips. We have to make sure that they are not expired, and that when they use them, please remind them to count 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi to 15. It's 15 seconds. Or if they want to use their watch, they could set a timer on their watch if they have an iWatch or something like that. But it's 15 seconds, and then you match it against the bottle. Because if it's longer than 15 seconds, it's gonna turn dark anyway. So this is the 15-second rule is important to prevent false positives. So you want to make sure those things are going on. And I'm out of slides. So I thought this was going to be 2 hours worth. Because I usually have questions and answers during the period of time that I do it. So how about we have some questions now?
If anyone has any questions, you can enter them in the chat box. We'll be glad to answer. Or if you want to unmute yourself, ask your question, that should be fine as well.
I don't see.
Sonia, I have a question here.
Yeah.
How would a school nurse be able to reach you if they have any questions? Do you have a particular email address you'd like them to use? Or would you like them to go through Thrive Kids and then us reach out to you as a liaison between the school nurses and the diabetic clinic?
No, they could feel free to email me if they want to at sonia.washington@lcmchealth.org. Sonia with a J. We love talking to the nurses. We have had nurses to, call us, and they're our eyes and ears out in the field. And it used to be when I first started years ago, before it was, it's just kind of bad out there now. I used to go to the schools and talk to the nurses and find out if they needed anything. But our nurses are really good about calling us and letting us know if they think anything is wrong at home with the family, um, what they should do, and we follow up on it. So they have been very helpful for us.
Okay, thank you. And have another question. When a student is newly diagnosed, how long is the honeymoon phase, and what exactly is the honeymoon phase?
That's a good question. The honeymoon phase can last anywhere from 0 days to a whole year. So the honeymoon phase, the body, a certain percentage of the beta cells are still present, like they're burning off, they're as the time go by, they're burning off. So they don't require as much insulin during the honeymoon phase. And they have a lot of lows during the honeymoon phase because we're trying to, through trial and error, get their blood sugar to insulin ratio just right. So it's very, during the honeymoon phase, it can last in some kids as much as a year. You will start seeing them come out of the honeymoon period because you'll start seeing high blood sugars just come out of nowhere. All of a sudden, they were real good 80s, 90s, hundreds. And then all of a sudden you start seeing 300s, 2, 3, 400s. Then you know that they're coming out of the honeymoon period.
And another question, I have a newly diagnosed student, December diagnosis, that always runs low, no pump, just injections. I'm giving her snacks multiple times a day for low blood sugars. How many snacks is too many? I already addressed with her doctor. I thought too much insulin.
It sounds like it's too much insulin. You should not have to provide snacks all day long to treat, the lows when you could just back off of the insulin. So I would probably talk to mom and have her to talk to her doctor and ask them to check her blood sugar numbers and to see if they can decrease her insulin if she's having a lot of lows, because that happens during the honeymoon phase, is that you have to keep backing off until they get to a point where they're okay. But if you're having to give more than 2 or 3 snacks a day, that's way too much.
Okay, and do you know which insurances are most likely to cover Dexcom or any other continuous monitoring symptoms?
Well, all of the Medicaids cover Dexcom for type 1s. The problem is that they will only cover it if they have blood sugars 4 times a day, and they have at least 2 lows of 50 or less. So, and that's dictated strictly by the insurance company and the DMEs. Now, some of the private insurances, you could just order it and they can get it through the pharmacy.
And Lydia, we will have this posted on our website, but I could also see about getting you a copy of the slides, if that's okay with Sonia. And let's see. Emily says, on my orders, my student is to have between 30 and 60 carbs for lunch. Should we avoid allowing over 60 carbs, or is it okay to go over a few carbs if there's something really good for lunch?
That 30 to 60 is a range that they should have during lunch. But as long as you cover them with insulin, they can have over over 60. You just have to, we want their weight to be in a good place. So if they're overweight, then you don't want them eating more than 60 every day. But if it's like a pizza day, or a day where they have something that's good, that ends up being 80 carbs, 70 or 80 carbs, then that's okay.
And I have here, when calling children's endocrinology with questions, it is often a lengthy process. Is there a way to speak to a nurse quicker, especially when we're calling about positive ketones? I know Sonia will probably have an answer, but I also want to offer my assistance in that process. If I can't answer the question, I know how to get in touch with endocrinology as well. But I'd like to hear your answer as well, Sonia, please.
Okay, well, typically we have them to call the nurse, the 896-9441 number, or you can call the 899-9511 number and ask the operator to put you through to the endocrinologist on call. And I know sometimes that's difficult to get through, but we have direct numbers, but we're in clinic a lot of the time, so we don't really give out our direct numbers because we may not be at our desk, because we're in clinic most days. So I would say 899-9511 would probably be, if you can't get the 896-9441, call the 899-9511 and ask for the endocrinologist on call.
You can also, and I'm going to put this in the chat, you can call 504-896-3082. That is my direct line, and I will assist you further with that. That's, our Thrive Kids team is here to make sure we coordinate between the specialist and you all, because we want to make sure that you're receiving your information in a timely manner as well. And let's see. Sonia, do you have any tips or education that you'd like for parents to be able to see, to gain information on the struggles with kids with diabetes, or any websites you can refer them to?
We used to refer them to the JDRF. because they have articles. Also, if you go to the NIH website, they will often have handouts that will have information on diabetes. There's a diabetes, it's NDD&K, I think it is. It's just go to the NIH.com and put in diabetes, and they have a lot of handouts that you could use to share with parents.
Okay. Okay. And I have here, explain the lab testing used to determine if a child is type 1 or type 2.
Oh, it's the autoantibodies. So we look at antibodies, we look at the glutamic acid, and we look at the insulin autoantibodies and the immunoglobulin. So we look at those tests and we determine if the autoantibodies or the what we call GAD, the glutamic acid, if any of those are elevated, then we know that's type 1. If they're not, and they're less than the range, then we know that they're type 2.
And what is the criteria for a student to get a pump?
The criteria to get a pump is really to ask your doctor if they can get. Now, Medicaid will not pay for pumps for type 2 diabetics. We're still working on that. They will only pay for pumps for type 1 diabetics. They will only pay for CGMs for type 1 diabetics. Recently, they sent us something saying that they would pay for type 2s if they were on insulin, but we haven't seen that as of yet. But basically, when depending on who your doctor is, you could talk to them about getting a pump. Tell them that you do your homework. Look up the T:slim website. Look at the Medtronic and look at the Omnipod, and go there with information that you already know about the pump. You would just like to get one, and and bring it to their attention, because our doctors allow our patients to get pumps. If they want it, they can get them.
Good. Okay. I have a newer diagnosed student, May 2020. He is chronically high. I have referred to the physician and suggested they recalculate him and the family. Is there anything else that I can do for him?
Unfortunately, that's all you could do, is to call the doctor, send them the blood sugar numbers, try to find out, if the child is eating something. A lot of times, is it a new type 1 or type 2?
Nicole, you can unmute yourself and tell us, is it a type 1 or type 2? Type 1.
Type 1. So, yeah, it sounds like if they're running high all the time, that they probably need some more insulin. Maybe, that may be one of the ones that is coming out of honeymoon early. And so they may just need some more insulin. We have our patients write down their blood sugar numbers in a book. We always give them a diabetes book where they could write down their blood sugar numbers, and then we look at patterns. I don't know, all doctors do it differently. So I can't say specifically, what how their doctor figures it out versus our doctors, but we always look at patterns of highs and lows. So if they're running high consistently, then we'll go up on the insulin. So the only thing you could do is send the numbers to the doctor.
Okay. And have you seen situations with a diabetic child in school with no school nurse, and how is this usually handled? Do you have that knowledge?
That is, we've had some students who have had to leave their school because they didn't have a school nurse. How do I say this? Not picking on them, but a lot of the Catholic schools, they don't have school nurses. So if they're in high school, then they usually just bring their stuff with them and they manage their own diabetes in school. If they're in grammar school, unless they have somebody over there who is diabetic and who is willing to take on that role, they really don't have the support.
Who sets alarm ranges on Dexcom 6? Can you resend monkey link? I will resend the monkey link. Who sets alarm ranges on Dexcom?
Actually, the Dexcom is set up by the parent. There is a customer service number that they can call, but the parents set it up based on their ranges. Now, some of them will set the high range up higher because they don't want to hear all of that beeping all night long. So it's pretty much the parents that set up the range. They know the range. They know that the range is 80 to 150 or 80 to 180. But if they're running, if overnight they run like in the 200s or something, that Dexcom is going to alarm all night long. So that's why some of them will change it to a higher number.
Okay. Laura says, I've had the same student for years and he has an Omnipod and a Dexcom G6 when he wears it. He is almost always over 240 with me, and when I question him and review the history, he almost always is under bolusing, if he is even bolusing at all. The diabetic educator has educated them many times, as well as myself. It takes me all day to get his blood glucose down to only start all back over the next day. Any out-of-the-box ideas?
Being a diabetes nurse can be a very frustrating job because you do have those students that will not bolus, and no matter what you tell them, they will not bolus. And so what I tried to do, because you've been having him for a long time, so that means that he was diagnosed at a young age. And what I tried to do, just like I taught y'all today, I tried to reteach those kids who were diagnosed as kids, because most of them, they don't really fully understand the management of their diabetes because it was taught to their parents and they just followed the regimen. Just like I was telling y'all, with the high blood sugars, to, help them understand that these are not just numbers, and let's look at this and figure out why you're at this number. So if he's running in the 240s and you recognize that he's not bolusing, then he needs to understand that when you bolus, um, you have to bolus for what you eat, and it's just a matter of putting in numbers. But if you don't bolus, and some of them will bolus after they eat, which means they're running. Tell them that they are chasing sugars all day if they bolus after they eat. They need to bolus before they eat, and the only thing you could do is try to educate, um, because unfortunately, they're pretty much in control. And unless their parents get involved, and I try to, get the parents involved and tell them to, really watch them and make sure when they're in their presence that they're bolusing. And when you're at school, you can make sure that they bolus by watching them bolus. Don't let them tell you, oh, I bolused already. No, no, do it in front of me.
Okay. And at what point should a school nurse contact CPS for students not having insulin at school?
Well, that is actually a decision that you have to come to. There are sometimes I've spoken to nurses and I've told them that maybe we need to get DCFS involved. If they are not taking their insulin and you see that they're having ketones all the time, and you've talked to the parents, and you've talked to the doctor, and they're always out of school because they're sick. I mean, we have over here, we have no problems calling DCFS because it's only for the safety of the child. If they're not going to do it, unfortunately, sometimes parents think that at the point that a kid is able to give their own shot, that they're able to manage their diabetes. But the two are not mutually, the two are mutually exclusive, because just because you can give a shot doesn't mean that you know how to manage it. So that's what we try to keep the parents involved in managing the diabetes, because as a kid, that you have to think of it. I always tell the parents, just think if you were a 10-year-old or you were a 12-year-old and you had a choice of whether to give yourself a shot or not, what are you going to do? So when you leave that totally up to them, then they're in control. And if they don't feel like taking the shot, they're not going to take it. So you have to try to get involvement with the parent. And calling DCFS is a hard thing to do. But at the point that you feel that this child is in a neglectful situation, then I think it's time to call DCFS.
Thank you. Should we be sending blood sugar logs to the doctor on a regular basis?
I only think you need to send logs when you see patterns of high blood sugars or patterns of low blood sugars. If you're seeing highs for three or 4 days in a row, or you seeing lows for 3 or 4 days in a row, then that's when you should send it to the doctor, because that means that they need a change.
Okay. What would be considered consistently as far as highs or lows? My student is all over the place, so just wondering the time frame to contact the doctor if there is no obvious reason for the cause of the high.
Well, if there's no obvious reason for the cause of the high and they're having highs, then it's time to contact the doctor, because if it's not a food issue, and they're saying that they're taking their insulin. Now, sometimes they'll tell you they're taking their insulin and they're really not. But if they're taking their insulin and it's not a food issue, then it's time to contact the doctor with some blood sugar numbers and tell them that, you know, the child has been running high for a week.
Okay. And last question as of the moment is from Verna, and I think this will be something I can take. The question is, we have an issue of trying to get someone medication trained and willing to be trained with diabetic care. This limits a nurse to be at one school if no one agrees to be trained. Any suggestions? I would like to have that conversation with you offline, if that is okay. I will put my contact information in the chat again. From personal experience as a school nurse prior to this position, I have a few suggestions, but Sonia, if you have any suggestions, I welcome that as well.
No, I mean, I think coming from a school nurse perspective is going to give them the best idea. So I would turn that over to you.
Okay. Verna, I want to encourage you to call me so we can have this conversation. All right, any other questions? All right, it looks like we are wrapping. Well, let's see. Barbara says she's been a school nurse for 23 years. Thanks for your knowledge. And can the PowerPoints be shared? This whole presentation will be on our website. And as I stated, we'll, as long as Sonia's okay, we'll share her PowerPoint. And sorry, and someone did ask if it was being recorded. Yes, it's being recorded. And we got another thank you very much.
Okay.
All right, so I'll go ahead and wrap things up. Sonia, you have anything left to say before I wrap things up?
No, I just want to say again that you guys at the schools are really a big help to us with being the eyes and ears to our patients on a daily basis. And we appreciate when you call us. Anytime you feel like you need to call about a patient, we're always available to answer those questions or help you as best we can. And like I said, check with Patricia if you can't get through, because it's very important that you get through if they have ketones.
Yes. All right. Thank you so much, Sonia. We truly do appreciate you coming on and helping us educate our school nurses. We are so grateful to have this partnership with LDOE and LDH and given this opportunity to provide this training session. We're working together to try and make sure we show you guys support as well as our student health. So thank y'all for all y'all are doing. Like I said, prior to this position, I was a school nurse for the last 2 years. I know the challenges that y'all face every day, and I can't even imagine what y'all are facing right now. So please, please reach out to us if you need anything. Thrive Kids is here to serve as a liaison to help you all with your students' health care. I want to give everybody a quick reminder to please fill out that survey that was placed in the chat. This is how you will receive your free CEUs, which will be 2 CEUs. And I highly encourage you all to email us at thrivekids@lcmchealth.org with any questions or concerns if you come up with anything, and with any immediate questions that are obviously in an emergency situation. We want you to follow the emergency protocols, but if there's something that you all need that is an emergent, please call us at 896-3082. And if no one has any other questions, we'll give you a little bit of time back to your day.